We've done a lot with CAR T cell therapy, at Hackensack and just as a medical community since its approval in 2017, initially for diffuse large B-cell lymphoma in a very refractory patient. So just talking about the DLBCL experience for a moment, those patients on the initial studies were very refractory, appropriate for basically hospice versus CAR T, had explosive lymphoma, and about 40% had long-term CRs, potential cure. So that's amazing compared to a patient population where you're expected to live less than 6 months. So in DLBCL, it's moving up to earlier lines of therapy. When we use a standard of care, patients are usually maybe 2 prior lines, not as refractory with these 5, 8 prior lines of therapy. They're in better shape to start. They have more flexibility to wait between CAR T cell collection and CAR T manufacturing. So in general, they're doing well. And then studies are ongoing as far as looking at potentially replacing autologous stem cell transplant. So even in the second line setting for high-risk relapse typically within a year of your front line, looking at randomized straight to CAR T versus standard salvage and autologous stem cell transplant. Each construct is basically doing that similar study, and soon I think we'll have data from at least the initial study of that concept in DLBCL. Development in low-grade lymphomas, development in mantle cell lymphoma, I think will be similar. So it's really exciting that we have our approval in relapse refractory mantle cell lymphoma. And I'm very hopeful, and I'm sure plans are already underway in terms of how to move that earlier in the treatment landscape, particularly for those patients with P53 abnormal mantle cell or blastoid mantle cell, pleomorphic, those high-risk mantle cell, using it earlier on, or maybe to eradicate MRD after frontline treatment if patients don't have an MRD negative CR. I think those are very exciting research questions that will be answered in the relatively near future now that we have approval.